neurological disease, and especially chronic neurological disease, is untreatable. That's what every doctor is taught, at least my generation. And here, these two, if you will, throwaways, they were neurologically unretrievable, just crazy, unbelievable cases, but two guys whose lives were essentially over. One that was likely going to die in a gun battle with police and so on, and the other one who just was going to kill himself. And I took a flyer, if you will, and applied something that Dr. Richard Neubauer had done and been heavily criticized for, which was treating their brain injury at a lower dose of hyperbaric oxygen than what had been accepted in the entire field, and was even considered by the definition, maybe not hyperbaric oxygen. And these guys not only got better, it totally turned their lives around. And it was so compelling and had such an impact on me that it completely changed my life. Show me any specialty in medicine that is practiced by rigid protocols. Nowhere. In fact, go back to the Hippocratic Oath in 500 BC in Hippocrates. I will prescribe regimen for you while doing no harm. That's the Hippocratic Oath. What was regimen? It was diet, exercise, lifestyle changes, trying to rebalance your life to treat your disease process. And most of it was nutritional. But the point was, it was individualized to you. And that has been the practice of medicine now for what, 2,500 years, and probably even going back, go to Chinese herbal medicine and so on, going back 5,000 years. It's always been personalized. But the reason hyperbaric medicine is so different is it goes back to us and the inability to define it and understand it.
This is How to Hyperbaric podcast, and in this episode, I'm absolutely thrilled to be joined by Dr. Paul Harch, a doctor who pioneered the use of hyperbaric oxygen therapy for neurological conditions and specifically for traumatic brain injury. Dr. Paul Harch is an author of Oxygen Revolution. He has done extensive research in the field of hyperbaric therapy. He's treated over 4,000 patients, and today we'll talk about different pressures that can be used. We'll talk about the essence of hyperbaric therapy, why it's considered to be a gene therapy, what are the prospects, and what are the trends in hyperbaric therapy. I'm as excited as you to dive in and ask all the questions. Let's get started. Let's start with your book. I have an honor of owning this book that you kindly signed for me, which is also makes it a little more special. It's called The Oxygen Revolution, Hyperbaric Oxygen Therapy, Breakthrough Gene Therapy. And before we move into why you call it gene therapy, can you tell us how this book came about?
Yes, I'd love to. And I want to say one thing before we start all of this. Our whole interaction here and your original invitation to me had nothing to do with trying to plug this book. The book is kind of a passive thing. It's out there and its reach and how it does and all the rest of that, I'm not real focused on and never have been. And so this is not an advertisement for this. But as we discussed a little bit earlier, the importance of that book is the story of why and how that was written. And the story essentially is that I was 35 years old and into a career that had gone off track, if you will. I'd been in a surgical residency and had a very bad car accident that nearly killed me. A lot of time in the hospital, et cetera. And after that happened, life had changed. And I took a medical leave from my surgical residency. And for the first time in, I don't know how many years, I had no plans, no future. I didn't know what I was going to do, but I had taken a medical leave to have another operation on my leg. And once out, one thing led to the next. I had to find a way to make a living and all. And I ended up eventually in emergency medicine. And in a long roundabout way, ended up, I was living in Denver, Colorado at the time, was at the University of Colorado Health Sciences Center, and I ended up accepting a job in New Orleans to work in emergency medicine, hospital-based emergency medicine. In the process, met a doctor who was head of a large group of physicians, and he had the emergency medicine, diving medicine practice for the entire Southeast United States, central Southeast United States, and Gulf of Mexico. And we had an option. It's not taught, diving medicine and hyperbaric oxygen, in medical schools. And you had an option. You could go get some training, learn, and start practicing in hyperbaric medicine under his tutelage and diving medicine. Or we just work in various hospitals where he had emergency department service contracts. And I thought this was very interesting. Again, nothing in medical school. And I was taught, in fact, in my third year of medical school, that hyperbaric oxygen therapy was, it's in the preface of my book, which the editors and publisher would not let me put in there until the third edition. When they asked me to write a third edition, I said under two conditions. Number one, you don't edit a word of what I'm going to write. And number two, we changed the title of this and the subtitle and focus on where this therapy has just incredible potential, which is brain injury. And that's how the gene therapy term got put in there. But so what happened is I wrote that third edition and told the story of, how this evolved. The point was that, this was a road of discovery for me. As I entered this diving medicine field, I started asking questions about our divers with brain decompression illness. And nobody had really understood it. U.S. Navy pretty much ignored it. It was not talked about. And of course, it's an unpopular subject, getting brain damage from scuba diving or commercial diving. But what happened was, and again, the story in the book, and the reason I wrote it was I was at a crossroads and had given my senior partner a year's notice that I was leaving the practice and likely the field of medicine if something did not change for me, because I was out of residency. I really didn't know. I didn't have any direction, and I was somewhat lost. And I sat down with myself and said, listen, you got to change your attitude. You determine your life, the direction, the decisions you make. And I delved into the diving medicine and what was going on in the brains of these divers. And in the midst of it, a number of these unbelievable cases came up, which are described in the book. The one guy who was going to kill all the diving company management over his brain injury. The other one who was in a jail on a psychiatric hold, essentially committed because he had tried to kill himself. And secondarily then accused of murder falsely. Just crazy, unbelievable cases, but two guys whose lives were essentially over. One that was likely going to die in a gun battle with police and so on, and the other one who just was going to kill himself. And I took a flyer, if you will, and applied something that Dr. Richard Neubauer had done and been heavily criticized for, which was treating their brain injury at a lower dose of hyperbaric oxygen than what had been accepted in the entire field, and was even considered by the definition, maybe not hyperbaric oxygen. And these guys not only got better, it totally turned their lives around. And it was so compelling and has such an impact on me that it completely changed my life. Neurological disease, and especially chronic neurological disease, is untreatable. That's what every doctor is taught, at least my generation. And here, these two, if you will, throwaways, they were neurologically unretrievable, unsalvageable, and it totally saved their life. The one guy went on, lived, another 20 years, died at the age of 65. I just found that out recently. The other one, though, is still going strong, went and got 2 master's degrees and does cognitive testing for traumatic brain injury patients in a major hospital program in West Texas. And when I saw this happen, I realized that this therapy, which had been so mischaracterized, unknown, etc., was unbelievable. And the medical profession had really missed it, had been completely misled because they didn't understand it. And so as the cases started accumulating, patients getting referred, cerebral palsy children, people with stroke, trauma, the first boxers, which was a project of my senior partner, I felt by 2005, 2004, I was so filled with this information and wanted to get it out that I went about seeing if I could write a book. And the message was to patients. It's buried in chapter 12, Roadblocks to the Future. And it just tells people that I presented the evidence for this in acute severe traumatic brain injury, showing that you can reduce mortality by 50% with just a few treatments right after the injury. And yet here we weren't using it. And the conclusion was, we can't trust the medical profession at the institutional level to do what's best for us medically. You have to go out and find therapies, find what you need, and be in control of your medical future. And that was the message. And I just wanted to spray this information out to the world, shout it from the tops of every mountain. And that's how that book got written. And the title of it, The Oxygen Revolution, was from my wife, Juliet. So the book went out, and what had happened, lastly, to get to your other point, once this discovery was made, I embarked for 10 years on a project to find out what else this could be used for, what other neurological condition, because here I was treating what was the foundation diagnosis for this subspecialty, hyperbaric and diving medicine, decompression sickness. But what I was treating was chronic brain injury. These were long after the accidents, months and months afterwards, considered untreatable in hyperbaric medicine. What else in the chronic brain injury, genre could this treat? And so for 10 years, I looked at every neurological patient and diagnosis that got self-referred or presented to me. And I realized that you can't do everything, that to really make an impact and make a contribution, I had to focus on one thing. And of all of those diagnoses, the one that seemed to respond the best, besides brain decompression sickness, was traumatic brain injury. And so the focus began on that. And then all of the presentations and interface with the federal government, the Department of Defense, all, CMS, the FDA, on and on and on. And to finally do the studies, to put the evidence in front of the medical profession that this is probably the most effective therapy for traumatic brain injury. Acute, subacute, chronic, severe, moderate, and mild. All severities, all acuities. And so that's where we are today.
Wow, this is amazing. It's such a powerful message to the medical community and to patients. Because as you said, nowadays, you cannot trust medical institution with decision on the treatment. You really need to do your own research. This is one of the reasons I really wanted to record this podcast, to make this information available to people who are suffering from neurological disease, from the consequences of traumatic brain injury, so they learn that this therapy is in fact available and that they can go to their medical provider and ask about it, because this is where it all starts. If we don't ask for the treatment, a lot of times, unfortunately, it is not being offered because, as you said, doctors are not being taught in medical school. It starts there. Very few hours on hyperbaric medicine, if any, mostly on diving medicine, goes very much unnoticed. Some strange specialty, how doctors treat it, maybe for people who really like diving or ocean and things like that, where in fact it's such a powerful tool. And as you said, it's the #1 therapy for traumatic brain injury. Before we move into post-traumatic stress disorder, which is a mental condition that people suffer after they've seen witnessed and experienced some traumatic event and can be quite debilitating. So before we move there, there is one question I really wanted to ask you. It says even on the cover of the book, gene therapy. Why do you call it gene therapy?
I'm going to answer that in 1 second, but I want to respond to one thing you just said. This is why I'm doing this interview and why I do as many interviews as are requested of me, because I saw one of my mentors, Dr. Van Meter is one of them, Dr. Richard Neubauer, who published more than just about anybody in hyperbaric medicine and made all of these contributions. And he was so disparaged and criticized in the US, not internationally. He was very much respected, but he never got any traction because he was a person in a little freestanding clinic. He had no attachment to an institution. So we made it a point of having an academic position at LSU School of Medicine in New Orleans. The problem is that didn't do it either. And I realized that the expansion of this field and the knowledge of it and dissemination of that knowledge has to occur through many different routes. Yes, we have to do the academic component and publish stuff and show this to the academic community, but you also have to show this directly to people and let them go about seeking this, demanding it, and so on, which is where we are. And then to your question, though, gene therapy. If you look at this therapy and the reason we have had such a problem with acceptance, criticism, etc., is that the hyperbaric medicine field, the doctors have never been able to define this in terms that the rest of the medical profession can understand. And in the absence of this and this ignorance, doctors, if they don't understand how a therapy or something works in medicine, they will not refer their patients for it. And so we look to the definition of what hyperbaric oxygen therapy is. It was defined as a treatment for a certain list of diagnoses. Now, it's just backward because that list, as it turns out, is different in the United States, Russia, China, Japan, etc. And certain was determined by a little group of doctors. So in other words, hyperbaric oxygen therapy is what we say it is. It's good for this list of diagnoses that we say it's good for. Well, and so we have this list of what now, 15 or 16 diagnoses. And I experienced this from the very start. 1986, when we opened the hyperbaric unit in this little community hospital up on the border of Louisiana and Mississippi, right on the edge of the Honey Island swamp, this little community hospital. And I go around to the doctors and, oh, yes, Dr. Harch, we just opened the hyperbaric unit here. I'm one of the emergency medicine physicians and so on. And they say, oh, yeah, what's that good for? And I'd show them the list. And now just listen to these diagnoses: decompression sickness, air embolism, carbon monoxide poisoning with or without cyanide poisoning, chronic bone infections, and that's my wife, partner, everything.
Nice
the reason
meeting
that
you,
this,
Juliet.
where this is and where I am is due to her. And but to continue, chronic bone infection, compromised flaps and grafts, thermal burns, and the list goes on. And the doctors look at these diagnoses and it's like, carbon monoxide and a chronic bone infection, how is that connected? I mean, and they finally say, okay, if you say so, and then they turn around and go the other way. There is seemingly no connection between those diagnoses. But in fact, there is. We're not treating the diagnoses, we're treating the underlying pathophysiology, the disease processes, and number one of which is inflammation in so many of these. But that was not understood. And as a result, the medical profession has never been able to accept this. So, what finally happened, if you look at all of the diseases, hyperbaric oxygen has had success or been applied to over its 363-year history. They are mostly wounding conditions and inflammatory conditions. And if we just take the wounding conditions for a moment, And 80% of reimbursed hyperbaric medicine practiced in the United States and all the hospital and wound care centers, 80% of it is due to two chronic conditions: diabetic foot wounds and radiation injured tissue. Well, what we do is heal these wounds with a daily exposure to increased pressure and oxygen. Eventually, the patients grow new tissue. Well, how do you grow new tissue? If you're stimulating non-healing tissue to grow new tissue, you have to stimulate the cells to multiply and divide. To do that, you have to go through the nucleus. You've got to do something to make the cell start to reproduce its DNA, the nucleus, the cell divide, etc., which means that we have to be doing something with our chromosomes and DNA. The concept of gene therapy, if you will, and that rise in pressure and oxygen stimulating our DNA was proposed by some plastic surgeons in 1997 who were doing wound experiments on rabbits, where they clamp the artery to the rabbit ear. Rabbit gets an ulcer at the end of it. And they were putting growth factors on it and finding that you grew new tissue. But they also exposed some of the rabbits to hyperbaric oxygen and also grew tissue. Well, where are the hormones acting? They're acting on the chromosomes. Where was the hyperbaric oxygen acting? It had to be doing the same thing. But the whole argument for it was in the title. Hyperbaric oxygen alters the ischemic oxygen capacitance of tissue. Where is DNA signaling in that? The article was just ignored. But over the next 15 years or 11 years, somewhere in there, a series of experiments were done that targeted individual genes and their products with hyperbaric oxygen. And all of these were positive. And finally, when molecular biochemical techniques caught up, and this goes to your answer or question, and the answer to your question, where you could do PCR analysis and mass gene array analyses. They did an experiment on human cells. Single hyperbaric treatment turned on over 40% of all the protein coding genes in our 46 chromosomes, which were 8,101 of the 19,000 genes. And the largest clusters turned on were the growth and repair hormone genes and the anti-inflammatory genes. And the largest clusters turned on were the ones that caused inflammation and cell death. So every hyperbaric treatment was stimulating tissue growth, inhibiting inflammation, and turning off cell death in areas of damage. Ergo, hyperbaric oxygen is a gene therapy, and it's acting at the epigenetic level.
So basically, we knew from 363 years ago that it's quite beneficial in the conditions of wounds and inflammation. And then many
Yes.
years later, after that, we learned that this was because it acted directly on the genes that were responsible for
Yes.
healing, repair, and inflammation.
Yes, so we have the most elegant, broad-based, wide-ranging, comprehensive gene therapy known to man. And when you think about it, it's depending on your belief, either the way we were created or deeply embedded in our evolution. If you believe in evolution and we came out of the oceans, you look at sea life. They are adapted and live at different levels according to the pressure of seawater. And so we have embedded in our genes the ability for our genes to respond to changes in pressure, and the same with oxygen. And that's the basis of this therapy.
And to your point, I'm asking this for the listeners to understand. We respond somewhat independently to the changes in pressure and to the changes in oxygen.
Yes, that's the dose of this. It's actually, this is a drug. And interestingly now, it is under the division of the Food and Drug Administration of the United States that oversees drugs, the CDER, the Center for Drug Evaluation and Research. And the reason is that it is the use of, partly, the use of 100% oxygen, which is a prescription medical gas. It is a drug. But pressure also is bioactive, even more so than the oxygen. and has drug-like properties the way we are dosing it. So we have a two-drug therapy, and it's the combination of pressure and oxygen that determines the effects based on your individual pathology, your genetics, and the time or point in the disease process that you're at. But even if you're not diseased, it has effects on our genes, and that goes to longevity.
Do you believe that maybe sometime in the future, when we design hyperbaric protocols, we would look into genetic SNPs and genetic makeup of a person, maybe sometime in 100 years? Or maybe
Potentially.
Yeah,
Yes.
I think so too.
That's what's being done with cancer therapies and other types of therapies, is looking at your genetic predisposition for diseases and how you might respond to various therapies.
Amazing.
Yes.
Let's talk about post-traumatic stress disorder. It's a condition that affects, I believe it affects every person on earth to some degree, because we all experience traumatic events to different degree, of course, that had some impact. And I just want to understand, do you consider post-traumatic stress disorder a type of brain injury?
I do, yes. And that was pretty much the conclusion that we came to in the systematic review we did last year, published last year, on hyperbaric oxygen therapy in PTSD, that based on the imaging that was done in the studies, what we were showing, and the conclusion was, PTSD can no longer be considered strictly a psychiatric disease. That the hyperbaric oxygen studies in patients with PTSD were showing abnormalities in functional brain imaging that changed and improved with the hyperbaric oxygen. So we were changing something at a microscopic chemical level, anatomic level, disease processes involved with it that were not just psychiatric and part of our consciousness, but were deeply embedded in our brain tissue. So yes, it is a type of wounding of the brain.
And if we think about hyperbaric therapy as a therapy for either a wound condition or highly inflammatory condition, then it falls exactly into the scope of effects of hyperbarics. What sort of prompted you to approach people with post-traumatic stress disorder with hyperbaric oxygen therapy? How did it all start? Can you give us a little story here, please?
Well, yes, of course. I'd like to say that I was so smart and forward thinking and had this genius idea, but no, that's not what it was. More or less serendipity. Remember, I said we were concentrating on trying to apply this to traumatic brain injury, do the studies, etc. And in the process, we went all over Washington. We were trying to get grant money, etc. And out of it, and out of the frustration, we had gone to the military. I had gone to Walter Reed, and we presented the evidence where I had treated patients in the previous year. So this was 2001, 2004. By 2004, went to the Walter Reed, but 2001 to the NIH, to all of these different groups, even the military. And we had showed them the patients that I had treated with traumatic brain injury in the previous, 12 years, trying to tell them that we had a treatment for our military, our service members, and it was just ignored. And so finally, as of course the Gulf War had happened in 2003, Gulf War II, and we were seeing this explosion, not to use a pun, in the number of traumatic brain injured service members, I started treating some of them. And the very first one actually came about, we put an announcement out that I would treat veterans for free. And it got picked up somehow by USA Today and published in USA Today. And a Boston judge saw this. His son was recently discharged from the military, had had 7 concussions, severe, excuse me, residual injury from the concussions, and also PTSD. And they answered the call, and essentially he came down to New Orleans in 2008, and I treated him. And by the 25th treatment, I was treating him for his concussions. I had no idea and had no thought that this would impact his PTSD. And on the after the oh gosh, by the I don't know what it was, eighth treatment or so, his headaches that he'd had intractably for 3.5 years were gone. And progressively, symptoms were better. And his PTSD was severe. I mean, flashbacks, terrible dreams, waking up so much throughout the night, beating up his girlfriend in bed, finding himself on the floor in the mornings because of these violent dreams he was having, and so on. On the 25th, after the 25th treatment, it coincided with the annual French Quarter Festival in New Orleans, where there over a weekend, roughly 400,000 people packed into the little French Quarter, all sorts of street music, bands, it's just a huge outdoor party. Someone with PTSD who can't tolerate crowds, noise, is avoidant, and so on. He walked in on that Monday morning and said, "My PTSD is gone." I said, what are you saying? He said, I'm not having nightmares. I'm not waking up. I'm not having the flashbacks. He said, this weekend I went down to the French Quarter Festival and I tolerated the whole weekend being out in these crowds. And I thought, wow, what happened here? What does this imply? And so I said, well, let's just finish your treatment. We took him through the full block of treatments. And then I repeated everything, his exam. And I had done functional brain imaging on him before. And here was this now brain scan showing dramatic improvement. And so I went and published the case report. And it was the first ever treatment that we know of someone with PTSD. And it just opened everything up. And it was followed then almost immediately by a series of other vets who answered the call for free treatment, 5 of them, some of whom had PTSD and similarly responded, then others with even more severe PTSD. And finally, we did the veteran study of the 30 veterans with traumatic brain injury and PTSD. And they had this huge reduction in PTSD symptoms. It was like a 40% reduction in the PCLM in a 30-day period of time, which for such a short period of time was, I think at the time, the greatest reduction in PTSD symptomatology that anybody had published. And that's how this all got going with PTSD. And now multiple studies have confirmed it.
And initially, what pressure was used when you just started?
Initially, it was at 1.5 atmospheres, 1.5 ATA of oxygen, which was the pressure that we had investigated in the 1990s. And, that I said we had found so much success treating traumatic brain injury. And so, the way you end up getting funding is you have to present evidence for what you've done. And that was the strongest evidence. So that precipitated the studies that were done at that pressure. But it's not the only dose that works for PTSD. And that was what we showed in the systematic review.
So for our listeners and for those who are viewing this on YouTube, you used different pressures, right? Not just 1.5. And you confirmed in your clinical work and in your studies that different pressures produced results.
Yes.
Were these pressures all sort of in the range of, I don't want to call them lower pressures, nor I want to call them milder, but let's say below 2 atmospheres. Let's call them that way.
They were up to and including 2 atmospheres. So anywhere from, if you look at one of the Department of Defense studies, they found success at 1.2 atmospheres of air. So between, at least the pressure between 1.2 and up to 2 atmospheres, there was benefit. There was even some benefit, mild, at 2.4 atmospheres in the one Department of Defense study. But it turned out that the lower pressures seemed to be, well, let me back off on that. Again, there is benefit across a wide range and across a wide range of oxygen. And
Dr.
that's what they
Harch,
showed.
can I reword this? Can I ask this question differently? You've treated multiple patients, probably thousands.
Well over 4,000.
Yes. And of course, you use different pressures. You had different age groups, males, females. But if we can generalize it, can you say that higher pressures, something over 2.2 atmospheres, are not tolerated as well as pressures below 2 atmospheres? Because this is what
Yes.
I've noticed, but I
Yes.
don't, of course, I don't have thousands of patients to rely on
Right.
with.
That's a fair statement. Yes. And actually, that is how we got to these first cases in the beginning. When I first started working in hyperbaric medicine, and still to this day, if you look at the standard hospital-based hyperbaric medicine practice and those 16 diagnoses, they are almost all at high pressures, 2 atmospheres and above. 2 to 3 atmospheres is the pressure range. And what happened is we were treating patients at those doses for their wounds. I started noticing that the ones who had previous neurological problems, like old strokes or old traumatic brain injury or so on, they were waking up. And I tell the story in the book about this. But I seemed to notice this more when I had dropped all of the wound care pressures for chronic wounds to 2 atmospheres. We used to run at the multiplace unit, we ran 3 dives per day in the multiplace chamber, plus, individual ones in the monoplace chambers. But at 8 a.m. and 3 p.m., it was a 2.4 atmosphere dive. At noon, we ran a 2 atmosphere one for a longer period of time for chronic bone infections. Well, if the patients missed their 8 a.m. dive, they either had to hang around to 3 or they missed it. And usually they just go home. They wouldn't wait around, get their treatment. So I asked the question, well, what's the difference between 2 atmospheres and 2.4? To my senior partner, Dr. Van Meter, and he said, well, no one really knows. So what I did was drop the chamber pressure to all 3 dives to 2 atmospheres. And what I noticed were some of these people with neurological diseases that we were treating for wound problems seemed to wake up, had more of a neurological improvement. And then, of course, those 2 divers came. And their treatment was really dictated by Dr. Neubauer, because the first one, that guy who was heading down to the diving company to kill all the employees associated with his accident, had been intercepted by his attorneys and brother and brought 20 miles from where he lived down the interstate and dropped him in the ER where I was working at that little community hospital. And I said, what do you want me to do with him? He's untreatable in hyperbaric medicine. And they said, well, you're the last one who treated him. You figure it out. And they left him. And I didn't know what to do. I got on the phone with Dr. Van Meter. And I said, what do we have for him? He goes, nothing. There's nothing in the field of diving medicine, but you might talk to this Dr. Neubauer. So I called up from the emergency room, Dr. Neubauer, the very first time I talked to him. We had a discussion, and it boiled down to, well, he never treated a diver, let alone a demented diver. What would you do? He said, well, you can try what I've done in stroke and trauma patients. Treat them at 1.5 atmospheres. Turns out that was the dose that the Germans had found effective in acute severe traumatic brain injury and acute severe stroke. So that is what I treated them at. And that then became the pressure that we started at. But we then found that even that was too much in some. So getting back to your question, yes, the higher you go, potentially, the more patients you find are intolerant of that, depending on how you deliver it. You need to give air breaks, etc. But as you get up into larger numbers of treatments, most people, in my experience, will come to a point of sensitivity, which goes under the terms of oxidative stress, oxygen toxicity, etc. But they come to a point of intolerance, extreme sensitivity to the oxygen at those pressures, and you have to adjust things.
Very
So
interesting.
yes, your observation is correct.
And how important is oxygen in this equation? So we get a patient with traumatic brain injury. We have hyperbaric, let's say it's a multi-place, so it's pressurized with air. We have an option of giving them a hood with an oxygen or not. How important is that supplemental extra oxygen to the pressure?
It's not clear at this point. You at least need some increase in oxygen. And that's been shown now, and that's the point we made also in that systematic review on PTSD and the other systematic review we published 2 years earlier on traumatic brain injury, that there was a minimum threshold, it seemed to be, for the additional oxygen. And more to the point, there is an interaction of the increased oxygen and the increased pressure. They are separate entities, but they have overlapping effects and they have interactive effects. The higher you go with oxygen pressure, you inhibit the pressure genes that are turned on just by pressure. So it turns out we are now finding out, let's go back to your example. Someone has an acute concussion and you want to treat them. What dose do you give them? Well, all of the experience has been generated with oxygen pressure doses, and quite a lot of it now, but almost none of it is published. So, there are doctors who have had a big experience with this, like Dr. Denham up in Chicago. I've had, considerable experience with it. There is this unpublished experience out there. The little bit of published experience that is out, which is one study out of North Carolina, didn't show a benefit. And it has to do with partly the way that study was done and very small numbers of patients in it. But if you look at the history of this field, it all developed first 300 years were treatment with pressurized air alone. The entire modern era of hyperbaric medicine has completely ignored it because it's outside the definition of hyperbaric oxygen that the medical society has established. And so all of that science has just been completely ignored. And the field started in the 1950s, two places, the Netherlands and the US. Well, the US and the British Navy, but primarily the US Navy, introducing oxygen into the treatment tables for decompression sickness. Well, what were the tables? Someone comes out of the water, they got decompression sickness, you take them to the depth of their dive. Let's say they dove to 100 feet. You take them to 100 feet plus another atmosphere of pressure on the same gas, air. Well, they found that if we gave them oxygen mixed in that, it treated the decompression sickness much faster. On air recompression, it took hours to days to bring them out of the chamber. But now with oxygen, it was much faster. Well, they found that they used the highest level of oxygen. Meanwhile, the Dutch were using maximum oxygen levels in people with conditions with maximum deficits of oxygen. Gas gangrene, carbon monoxide poisoning, blue baby operations, etc. So the entire modern era started with using maximum oxygen levels at pressure to treat all these different conditions. Well, now we're finding out that in fact this lower range is bioactive even for some acute disorders, but the information is not out there and it's not published. So when a patient comes to me, I can't tell them, they want what I've done that works. They want me to treat them with what I know can help them. Well, I don't gamble with, what we don't have a big experience and published experience for. But what I am doing now, and what we tried to do, we thought that 1.5 atmosphere dose was magic in 1989. In 1990, when we treated the first patients there. So for a decade, we looked at that in all of these different diagnoses. But, and the way we were trying to diagnose it was we do a brain functional scan. Next day, they go in the chamber at a given dose of hyperbaric oxygen. 3 to 4 hours later, we'd rescan them. And But if we didn't see an improvement on that second scan, you'd have to give them another treatment at a different dose. It's expensive, involve radiation, et cetera, et cetera. Now what I'm doing is looking at a patient's brain live in the chamber, and I take them through a dosing profile where we look at brain activity live in the chamber. And I find where their brain is functioning the best at what dose of oxygen and pressure, and now treat them at that.
I love that. I listen to this and I'm thinking, I almost want to become a patient, but I don't, of course. Just to experience, just to go through this experience and to see how it works, because this is amazing. And it only proves the fact that those protocols, they need to be personalized somehow, because we're different.
My God, exactly. I mean, this is what I've been trying to say for years. Show me any specialty in medicine that is practiced by rigid protocols. Nowhere. In fact, go back to the Hippocratic Oath in 500 BC in Hippocrates. I will prescribe regimen for you while doing no harm. That's the Hippocratic Oath. What was regimen? It was diet, exercise, lifestyle changes, trying to rebalance your life to treat your disease process. And most of it was nutritional. But the point was, it was individualized to you. And that has been the practice of medicine now for what, 2,500 years, and probably even going back, go to Chinese herbal medicine and so on, going back 5,000 years. It's always been personalized. But the reason hyperbaric medicine is so different is it goes back to us and the inability to define it and understand it. So what happened is, you got a diabetic foot wound, I put you in a hyperbaric chamber, I treat you at whatever dose, and it worked for you. Well, another diabetic foot patient comes along and treats at what worked for that patient. Oh, well, I'm going to give them the same thing. And pretty soon, by habit, we came up with, well, you have to treat these diabetic foot wounds but if you even look at the dosing guidelines, the range of pressures between 2.5 atmospheres, even greater, for 60 minutes, 90 minutes, 2 hours at a time. There's variation there. And protocols came up, and everybody now wants to just plug a protocol in for a diagnosis. That is not the way you practice medicine. You are different from me, are different from everybody else. Now your disease process, acting on your genetics, your anatomy, your everything, is different from everybody else's. And while there may be some overlap and similarities and some response across a range of pressures and oxygen levels, the ideal thing is to try to dose things according to you and your disease, which is the practice of medicine.
Thank you for this amazing conversation. I have so many thoughts and ideas in my mind. I'm thinking, with wellness protocols, people who do hyperbarics for wellness, would it be okay to do just with pressure, or maybe give a little bit of oxygen at the beginning of the treatment and maybe 10-15 minutes and continue just with pressure, things like that?
Yes. Well, we need to do this again, but yes, and just to be clear, just pressure. We don't have a way of delivering just pressure.
That's true.
Unless you give a hypoxic mixture of air, as you're compressing the patient and getting them to whatever level so that the oxygen level just stays the same. When you compress air, or any breathing gas, you increase the pressure of all the component gases. So the oxygen pressure is increased. The percent may not change, but the oxygen pressure is, and that is what is bioactive, is the pressure of the gas. So yes, getting to the wellness thing, it kind of begs the question of, well, how well are you? And, at any point in our lives, we are the sum total of everything that's insulted us. Carbon monoxide that you've been exposed to, let's say, running your lawnmower or go-kart or your car in the garage, for instance, or, let's say a very mild traumatic brain injury that causes some injury, or oh gosh, any number of things. The chemical bath that we live in, the things in our air that we're breathing, the pesticides, herbicides, food additives, chemicals, not to mention alcohol, tobacco, drugs, etc. All of these things potentially injure us. And such that right now you and I are the cumulative sum total of all of these insults. So even though you look healthy and I may be healthy, whatever, how well are we? Such that now treating you with hyperbaric treatment for wellness, you in fact are treating these cumulative insults in addition to, as going forward, maybe treating additional ones that you incur and trying to maximize and keep yourself functioning at a higher level.
I love that. And the best prevention tool, not only
Yes.
the best
Yes.
tool to cure, but the best prevention tool that we have. Let's keep spreading the word. I really appreciate this conversation. As I said, I was absolutely mesmerized, and it just had, all these thoughts in my head about the different uses of hyperbaric therapy, maybe a deeper understanding of what it does, pressure versus oxygen, traumatic brain injury, how common it is. Really, people come with very severe symptoms, but we all experience, as you just said, some form maybe of very mild traumatic brain injury that needs to be treated, and how powerful this therapy is.
It is. It changed my life.
It changed my life and so many people around me, thousands and thousands of people. I'm very happy that it's gaining momentum. Even 10 years ago, it was still something, Michael Jackson slept in, I'm sure you've heard this, and now we have so much more knowledge available. And
Yes.
I really appreciate, I just want to say at the end that I really appreciate all people who tune in, who keep learning about hyperbaric therapy, watching those amazing interviews with experts in the hyperbaric field, educating themselves and bringing this information to their physicians, prompting
That's the
physicians
key.
to learn more.
That's the key. We have to reach the doctors because my generation of doctors was taught this was a fraud. And even the newer generation of doctors do not understand this therapy because of the way it's been defined. And if they don't understand it, they don't refer their patients. The patients don't care. They don't care how something works. They only care if it works. And that's the same with the FDA. The FDA doesn't care to know about mechanism of action. In fact, the most common phrase in the physician's desk reference, which is the compendium of all of the commercially available drugs cleared by the FDA for sale in the United States, most common phrase in there is under mechanism of action. No known mechanism of action. It's irrelevant to the FDA. All it matters is, does it work and does it harm people? And of course, you look at patients. Show me a man with erectile dysfunction who's getting a prescription for Viagra who says, oh, doc, I can't take that until I know the mechanism of action and how it works. Not a one of them. It's give me that stuff. They want it. And it's true of any medication, prescription. Herbal therapies, doesn't matter. People use it if it works and want it. Forget the mechanism of action. But doctors, we have to reach them and they have to understand what is now available and the understanding of hyperbaric oxygen, which I was so misled about when I was a medical student. All of us were and continue to be.
Yes, I don't even remember. Maybe a couple of hours in medical school about diving medicine, if any. Maybe
2014,
yeah.
In 2014, we did a survey of American medical schools, and 75% of them taught nothing about hyperbaric medicine in their basic science curriculum. And the other 25% had a fraction of a lecture or maybe one lecture about it. So essentially, that's 2014, 11 years ago. It's not taught.
Time for some changes.
Yes,
time for some changes. Thank you very much.
my pleasure. Have a good day.